This session start with a talk from Professor Said, and then we will have 10 free papers. So please.
Thank you very much, Mr. Chairman. Well, I like very much this picture which you put as a sign for this Congress with the lipstick building and the Viking ships. The subject of this lecture is diaphyseal non-union. I work in Asyut University in Egypt. Definition of non-union, some people like to define it chronologically, delayed union up to 6 months, and non-union more than 6 months or about 8 months, okay? Some others like to go biological, that is, arrest of the reparative process without achieving union, irrespective of the length of time. And I think this is more logic. Causes of delayed union, 2 major causes: instability, lack of enough fixation of a fracture, and disruption of vascularity as a result of trauma or previous surgery. Other factors that lead to non-union are a non-compliant patient, gap between fragments, infection, neuropathies like diabetes and other neuropathies, and smoking also is blamed for delaying union. Most of the delayed non-union that we see nowadays follow internal fixation. It is usual to classify non-union into 2 types. The hypertrophic, also called reactive or vascular non-union, and the atrophic, that is the non-reactive, may or may not be vascular non-union. Now we come to a failed intramedullary nail. This patient with this type of fracture, after nailing somewhere, presented with this post-operative X-ray 1.5 months after the operation. There's a big splinter of a medial fragment here, making the fixation of the upper fragment very poor. After 6 weeks again, the patient came with a broken locked nail up and pain, and the patient even felt cracking. So this means 3 months. Of course, you don't need to stay until you declare that this is non-union. Everybody will say that this fracture is not enough stabilized. Also, there is deformity, so this is not acceptable. Let us then operate directly. And the operation here is conversion. We remove the nail because I think nailing another nail will not provide any fixation again. So plating is the best, and this is just a couple of months later showing healing going on. The other type of treatment for failed intramedullary nailing is an exchange nail to remove the nail. This is an ununited fracture here, but the fracture did not unite, and the nail broke also here. Removal of the broken nail and reaming of the medulla to a wider size, and putting a thicker nail resulted in union. This method of exchanging nailing is not recommended for comminuted fractures and is not also indicated in fractures of the lower third of the femur. The other method of treating ununited fracture after nailing is augmentation plate. Keep the plate in situ here and apply a short plate to prevent rotation and also to compress the site of the non-union. This is a DCP plate. Better if you use a broad DCP because of the staggered position of the screw holes to go in front and behind the nail. And this will result in union. As we can see here, the union goes directly here. This method of augmentation actually gives regularly good results in all the literature that I have seen. All the authors mentioned that this fracture treated by this method heal directly. In this case, there is no deformity. The fracture is ununited because it is a conchared nail. The fracture is ununited, so this will augment the fixation and will prevent rotation. However, in this patient, there is a wide gap here, as you see, a non-union here, and the nail is short. That's why it did not unite, though it is interlocked here. And this big butterfly is widely displaced, and there's overlap. There's also angulation at that site here. So this is not acceptable. Then we have to do some sort of direct reduction of these fragments by excision of the fibrous tissue here, removal of these locking screws, and reduction of this butterfly fragment. We reduce it back to its position, and that's how it looks like now. Okay. The gap is now closed here, and the alignment is restored, and the locking screws are removed here. And we get consolidation of the fracture directly. In the first case, I have shown here of a short plate here. This short plate can be put in a small incision that sometimes needed even to put a bone graft without putting the plate. A bone graft if the fracture is ununited. A small incision for the bone graft, you can also apply this plate. And this is a reduction. This is the reduction of the non-union with the nail in situ. Even with this amount of displacement, this is 3 months after surgery, a good amount of displacement, angulation, and showing no union, and the patient is complaining of pain. So there's no need to stay for 6 or 8 months. We have to interfere, and we still, by removing these screws closer to the fracture and manipulating this, we can achieve reduction and applying a rather long plate because we have manipulated, and then we have to put bone graft to fill these gaps here. So you can still do direct reduction of the fragments after excising the fibrous tissue at the non-union site and after removal of the locking screws. The same technique can be applied for the humerus and for the tibia. Now we come to non-union after plating. 3 methods are available. If there's good bone stock, then we can do replating, intramedullary nailing, or locked screw-head plate. If there is osteoporosis, then we don't like to apply plate. We are left with the 2 lines of treatment here, intramedullary nailing or locked screw-head plate. This is a previously infected non-union of the ulna, dislocation of the radial head. After 6 weeks and the CRP getting down, after removal, after doing the first stage operation of debridement and metal removal, here another plating, after putting here a strut graft, restoring the length of the ulna, and if you restore the length of the ulna, the radial head automatically reduces. And then this is a plate and consolidation. The locked plate is a very useful implant, especially so if there is osteoporosis. This is a failed plating. Actually, it was also infected. So first stage removal of the metal and debridement. And second stage is application of an interlocked plate, which results in union and consolidation of the fracture. It's very good, especially in osteoporosis. In atrophic non-union, this patient was treated with a plate. This is a firearm injury, and it failed to unite. It is an atrophic non-union. Removal of the plate and putting a reamed intramedullary nail here solved the problem, and we got consolidation. Reaming, well, the bone dust produced by reaming is some sort of a stimulus of osteogenesis. Hypertrophic non-union. This patient had an intramedullary nail which failed, and we are left only with a part of the locking screw, and also had a plate after that which was broken again without achieving union. So removal of the plate and putting an intramedullary nail resulted in union of this hypertrophic non-union, and we got consolidation there. If there is osteoporosis, well, with this degree of osteoporosis, we just the ghost of the bone is showing, no implant can be used except the intramedullary nail. It is quite a long implant that will neutralize the forces applied to the bone, and it results in union. Failed plating again. This is a failed plate. The screws are broken, and the screws here are pulled out. We are close to a joint. That's why then locked plate is the ideal treatment resulting in union. So osteoporosis and close to a joint, we apply a plate, a locked plate. Even if you are having a very short metaphyseal fragment, again, a locked plate can solve the problem. Now, just a few hints about this technique. This patient had an intramedullary nail which failed. You can see the shadow of the track. And then he had a plate which also failed because there is avascular bone here. So the first stage of the plate was removed, infection. It was also infected. After the substance infection and closure of the sinus, the patient had the second surgery of removal of the necrotic bone here, bone graft, strut bone graft from the ilium here, and then a plate here. Because of the severe osteoporosis of the distal fragment, the technique of passing the screw through the tibia, through the interosseous space here to the fibula to get purchase of the fibula. The fibula is a cortical bone and does not share osteoporosis early like the tibia. So, now we have got 4 cortices here for fixation. So this technique is very valuable in fractures associated with osteoporosis of the tibia. Another technique for osteoporotic humerus, another technique, as you see, it is very, very osteoporotic bone. This is a fibular graft tucked into the medulla of the humerus on one side, and then you pull it through a small window here, pull it down by means of a pointed instrument, pull it down until it comes across the fracture site, and apply your plate. This is a very good technique and is useful, so remember it if you have an osteoporotic ununited fracture of the humerus. This is a case that we come across that you don't see in the Western countries. This is a patient from sub-Saharan country that came to our clinic for treatment. He had chronic osteomyelitis as a boy of 9 years, and he had a massive diaphysectomy and resulted in non-union with shortening. This is what remains of the femur, and this part is just, again, a ghost of the bone that can't hold any screws. No screws can be put here to pull any type of screw. The lateral views showing here the patella ankylosed, bony ankylosis to the lower segment of the femur. And he has got 18 centimeters shortening of the femur and 10 centimeters shortening of the tibia. As you see here, his foot is hanging up, and it is flail, absolutely flail, and hang. Okay? So we found that solving the 2 problems of non-union and shortening in one stage would be a failure, because this type of bone would not allow distraction at all. No pin or wire will hold in this bone. So condylar plate and bone grafting was put as a first stage here until we got union of the fracture, and then we provided the patient with this type of orthosis with a shelf here between the two bars, and the foot of the patient is here, and all of this is artificial, just extension. And we sent him home for 6 months to his country to put weight on so that we get better quality of bone for distraction. This is the view from the front, this is his foot, and this is the artificial foot. And then after that, we came and we did a simultaneous unilateral frame for lengthening of the femur and of the leg simultaneously. This is the fracture before lengthening. Here, as you notice, we have shortened, we removed this plate, and we have put a shorter plate, and we put the Schanz screws through the holes of the plate, again to provide cutting into this very soft bone. It is of better quality, but still can stand pulling. The upper fragment has got better quality, and we started distraction, as you see here. And this is at the end of the distraction. Now we come to a problem of non-union and bony defect. If there is a small defect, we can treat it by autogenous bone grafting, medium-sized defect, bone transport, and large defects, more than 10 centimeters, we think of vascularized bone graft. Let us see examples of this. This is a small bony defect. This patient had several operations to treat a fracture of the femur and his non-unions, including plating several times and removal of the plates, infection, Lizarov, and so on. He had all of these lines of treatment and failed to unite with a good amount of shortening. So direct or acute distraction using the femoral distractor, the AO, and we gained a length of 5 centimeters here, strut graft iliac to fill this gap results in union of the fracture. We gained 5 centimeters of length. Medium-sized defect is treated by a fibular graft. This is a non-vascular, just a fibular graft removed from the leg, put into this place, and resulted in union with the restoration of length and function of the forearm. This boy had a 9 centimeters bony defect, and this is during bone transport again. Bone transport. This is the fragment transported, and this is after reaching the docking site. And this is the regenerate here. So the medium-sized defects. With a defect of this size, all of you will think of amputation, of course, but in our culture, amputation is not an acceptable option. This patient had a defect of 26 centimeters. Nothing can be done here except a vascularized fibular graft. And for this length, vascular fibular graft, is notorious for complications, including stress fractures, non-unions, and so on. The patient had all of these, and he had plates here, he had treatment by the screws there, and so on. In the end, after 3 years, he has got this type of leg. Now we come to infected non-union. Infected non-union, if it is actively draining, it will need debridement and external fixation if it's not fixed. If it's fixed by an internal fixation and it is stable fixation, then we don't remove the implants. But if it's not, if the internal fixation device is loose, then we remove it and we apply an external fixator. In 2 or 3 weeks, usually the drainage improves, and then we can apply cancellous bone grafting to the site and keep the external fixator. For the previously infected, with the skin closed and the signs of infection have subsided, the C-reactive protein getting down, then we treat it as an uninfected fracture, excision of any avascular bone or scar tissue, and then we can fix by plate or intramedullary nail or external fixation the way you like. Cancellous bone grafting can be used if the non-union is avascular and if there are gaps. Example here, this is an infected non-union after a bullet fracture. bullet. Okay, we can see a bone sequestrum here, and so on. So debridement, all necrotic bone is removed. Loose implants are removed, if any. Polymethyl methacrylate beads are useful, and application of external fixator. And aligning the fracture results in union. Infected non-union, if it's infected and heavily draining, then you have to use two-stage surgery. And the first stage of removal of the hardware and debridement, and when it subsides, then you can treat it the way you like. In this patient, he had intramedullary nailing, and this is union. This patient, this poor patient, had infected plate, infection after plating, and you can see here big sequestra. These are the sequestra removed from this patient with loose screws, no fixation, so all of this was removed. And then the limb was scarred, and this is a unilateral fixator used here, and this is another fixator used here. We had no reconstruction fixation at that time. This is a very old case. And we are doing bone transport of this fragment down. We moved it down. It was very difficult to pull because of the scarring. Ultimately, we achieved lengthening of the upper fragment, but we did not achieve union. So a plate solved the problem. That's the last slide. This is the comet Bob Haley crossing the sky of Cairo above the Great Pyramid. Thank you very much for your attention.
So we thank Professor Said for this most elegant review, and I think we have time for a couple of questions. Please address yourself, your name and where you work, and use the microphone if possible.
I'm Nagi Sabit from Cairo. Thank you, Professor, for your comprehensive lecture. What I want to ask about most of the cases, the medial cortex of the femur was comminuted. So what's the role of the medial cortex here? And can we suspect this fracture will go to non-union, so we'll do some safeguards against from the early beginning, just to put a nail and the plate or to put bone graft or something like that?
You mean a fresh fracture with a medial cortex comminuted? Fresh fracture, medial cortex comminuted. Ideal treatment is an intramedullary nail. Ideal treatment, okay, from the beginning. But if you have already put a plate, it will fail. So after, you may prevent failure by augmenting the healing by a cancellous bone grafting on the medial side, and also the decortication of the femur. Bone grafting as a primary procedure is not recommended, because to put a bone graft on the medial side, you have to strip too much. So this is not recommended. Okay, so after a few weeks, then you can apply the bone grafting technique.